Okay, good morning. My name's James Danger, and in this video, I'd like to talk about a recent paper asking the question, can artificial intelligence models provide reliable medical counselling to fertility patients? This publication occurred in Reproductive Biomedicine Online in August. They always take a long time to post it onto PubMed, a wide variety of authors from many different countries. Okay, so by way of background, IVF is awash with information, and all clinics have a huge commitment to providing counselling before, during, and after treatment. But can artificial intelligence models provide reliable medical counselling for fertility patients? And the authors make a comment, anything in inverted commas is theoretically a quote from the paper. Although recent studies have shown that AI can support diagnostic tasks and interpret complex data, concerns remain regarding its ability to deliver personalised and accurate counselling in a real-world clinical practice. To do this, the authors, well, at least two of the authors, two professionals, now devised 12 questions that clients may consider asking the doctor or ChatGTP. They sent the replies to two different specialists and asked them to make a comment, and they posted the same questions to ChatGTP and Gemini for their reply. So they took all those replies from the four different sources, 12 questions, and sent them to 8 leading international experts from all around the world who were blinded as to the source of each reply to act as referees. The referees were asked to rate each response on a scale 1 to 10, where 1 they disagree and 10 they agree. The ratings for each replying doctor were compared with those of ChatGTP and Gemini, both for the overall set of questions and for each individual questions. And basically, this is what they found, that for Dr. A, there was quite a good consensus that the advice he gave was in agreement with what those referees did. Slightly more variation with Dr. B, but even for Dr. A, you notice there are 2 questions that everyone disagreed with what the doctor said. So even though for 10 out of 12 questions, they really agreed exactly with what he said, for 2 of them, they just did not agree. The ChatGTP was better than the Gemini, but there was much more variability in how the referees scored their responses. So let's have a look at the questions. There's 12 questions. First one, I'm a 30-year-old and undergoing IVF due to sperm abnormalities. Should I consider PGT-A? I'm a 40-year-old and have 2 eggs retrieved, both of which were fertilized. Should I have a transfer to a cleavage stage embryo or culture the embryos to day 5 with the aim of transferring a blastocyst embryo? I'm a 35-year-old and planning a frozen embryo transfer in the natural cycle. I have received HCG triggering, but should I take a luteal phase support? Question 4 was, I'm a 30-year-old single woman. Should I consider egg freezing? Probably the most relevant question of all. I'm a 32-year-old and pregnant after a fresh transfer. I'm receiving vaginal progesterone for luteal phase support. Until what week of gestation should I continue taking luteal phase support? That is a very medical question. I'm a male patient undergoing IVF due to sperm abnormalities. Should I be taking antioxidants? That's a reasonable question asked by a lot of people. I'm 38 years old and have been diagnosed with low ovarian reserve. I'm planning to start IVF. Should I take DHEA supplements? That's also a really good question. I'm 38 years old and undergoing IVF. I've had 3 failed blastocyst transfer. Should I consider endometrial scratching? Number 9, I'm a 38-year-old and have been diagnosed with endometriosis, including a 5-centimetre endometrioma. I'm planning to start IVF treatment, but should I undergo surgery to remove the endometrioma before IVF? I'm 30 years old and was diagnosed, and not everyone's, I'm a 30-year-old and was diagnosed with unexplained infertility. I'm about to start my first IVF cycle. Should I opt for standard IVF or ICSI? Question 11, I'm 25 years old with PCO and about to start ovulation induction treatment. Should I take metformin regularly? And the last question is, I'm 35 years old and undergoing a frozen embryo transfer. Should I measure my blood progesterone levels on the day of transfer? Okay. Let's just look at a couple. I picked out 4. It's too much to go through the whole lot. The first one was, this is about PGT-A. I'm 30 years old and undergoing IVF due to sperm abnormalities. Should I consider genetic testing? Dr. A This is actually really good. Everyone should actually read all these replies. They're quite informative how different they can be. Dr. A says most randomized trials note a similar cumulative live birth rate with PGT-A, yet a probably higher rate per transfer and a possible decrease in miscarriage rates. That's absolutely correct. Pros in your case, possibly less transfers under pregnancy is obtained. The cons, the cost, the need to grow embryos to blastocysts, the potential embryo damage, the lack of long-term safety data, and questionable benefits for success. It seems the cons outweigh the pros in your case, but it's your decision. Dr. B says, as PGT-A is not proven effective in increasing live birth rates in young IVF patients, and since this technique requires additional cost and complexity, it seems better to avoid PGT-A in your case. ChatGTP, on the other hand, said, PGT-A is generally used to screen chromosome abnormalities, especially in cases of recurrent miscarriage or advanced maternal age. While sperm abnormalities can contribute to DNA fragmentation, PGT-A is not always necessary unless they have additional risk factors. And poor old Gemini basically says, yes, do it. PGT-A is a viable option for you. PGT-A can help identify embryos with chromosomal abnormalities, increasing the chance of a successful pregnancy. So my little comment is, what was not said was only euploid embryos transferred. If there's no euploid embryos for transfer, there is no transfer. Therefore, there is a risk of increase. Therefore, there's an increased risk of a cancelled embryo transfer. I think Dr. A gave the correct advice. For sperm abnormalities, PGT-A does not help. This has been shown recently using donor eggs. The second one I'd like just to make a comment on. I'm a 35-year-old planning a frozen embryo transfer in a natural cycle. I received HCG. Should I take the telophase support? The telophase abnormalities are uncommon because of infertility, yet there seems to be an advantage to the telophase support for all patients after natural IVF. I think that's correct. High live birth rates with progesterone supplementation have been demonstrated in several randomized controlled trials and meta-analysis, yet not for the TEAL HCG. Noticeably, there is no clear consensus on the dose or type of progesterone you should take. Thus, I would advise on progesterone as a TEAL support after your transfer. B said, yep. As researchers report on improved live birth rates using progesterone supplementation in natural cycles, do it. ChatGTP says, yep, the telophase support is often recommended, even in natural cycles, as progesterone supplementation can improve implantation rates and early pregnancy support. And the old Gemini says, yep, the TEAL support is typically recommended after HCG triggering in frozen transfers, even in natural cycles. It helps support the endometrium and improves implantation chances. Actually, all those are true. And in fact, my guess is most people would take the telophase support rather than relying on the endometrium, even though there are about 10% of cases with natural cycles where the progesterones are quite low after HCG. I think it depends on the size of the follicle and how well vascularized it is at ovulation. I'm a 30-year-old, was diagnosed with unexplained fertility, about to start IVF. Should I opt for standard IVF or ICSI? Unexplained infertility is frustrating, and many couples often wonder whether this stems from an abnormal natural fertilization of the egg by the sperm. Yet large studies and meta-analysis do not support the benefit of ICSI over IVF birth rates in unexplained infertility. Moreover, ICSI may be associated with a higher risk of genital abnormality. Would advise on IVF in your case, noting the 5% risk of fast fertilization, and I think that is a really important thing to point out. The use of ICSI for unexplained infertility has been a matter of debate for many years, with no clear conclusion so far. For making a personal decision on this matter, it's better to receive personal consultation from your doctor. Okay. ChatGTP says standard IVF is usually recommended first, as fertilization rates are typically normal. ICSI is considered if there's a fertilization failure or poor embryo development in previous cycles. And Gemini says, in case of unexplained infertility, standard IVF is often the initial approach. ICSI may be considered if there are concerns about sperm quality of fertilization. So it's interesting here that both ChatGTP and Gemini have both taken to heart what is the dialogue that's going around. People want to use ICSI more, but there is a pushback saying that when you use it, there's no advantage. There's fewer eggs and fewer embryos, but the pregnancy rates at the end of the day are basically the same. So why spend the money on it? And the last one, which I think is the most relevant, because I've just done a recent video on it. 30-year-old single woman, should I consider egg freezing? This option carries promise, but requires an honest acknowledgement of limitations. At 30, 15 eggs translate to about a 64 to 71% live birth rate, while ovarian marker reserves can help predict whether your goals will be attainable with one cycle or more. That's AMH. So the pros: potential assistance in future advanced age fertility. The cons: the cost, the treatment side and risks. Never 100% promised insurance policy. No long-term data on success and safety needed for IVF. Actually, on that point, there's quite a lot of information considering the risk of preeclampsia and postpartum hemorrhaging for donated eggs, but this doesn't occur. It seems to be for when your own eggs are put back. But there's some question about whether it's due to artificial cycle management of FETs. Dr. B says, freezing your eggs in your 30s may offer increased chance of live birth at older age when a woman's eggs become fewer and the natural chance of birth rates are low. However, egg freezing is not a guarantee for birth and is associated with significant costs and some discomfort. Of note, egg freezing becomes less effective after age 30, so it's better to be done before that age. ChatGTP says, yep, egg freezing is a good idea for preserving fertility if childbearing is delayed. At 30, your eggs are still good quality, increasing the chance of successful future pregnancies. And Gemini says, egg freezing is a viable option for preserving fertility, especially for single women. It allows you to have the possibility of having biological children later in life. One important point is that the eggs frozen to a 30-year-old woman will always be a 30-year-old, regardless of when they are used. Even though there may be small decreases in live birth rates using eggs in older women, this is very marginal, and you should see my video on that topic. There's a couple of videos on the topic. Okay, so my response to the replies: the AI replies are short, simple, and largely proactive. They seem to encourage action. Yep, freeze your eggs. Good as a starting point to understand what questions to ask your doctor. But the clinical replies are more balanced, complicated, and nuanced. They give reasons both for being proactive and being cautious. And in most cases, the pros and cons are presented, especially by Dr. A. So let's just quickly look at the variation between them. I'll go through them very quickly. So Dr. A, these are the mean scores by the 8 referees: 9, 10, 8, 2.5. So ChatGTP, this is one looking at sperm abnormalities, PGT-A. ChatGTP is very similar to the doctors, but Gemini is way off it. So it's significantly different. 40-year-old having 2 eggs frozen should have day 3 or day 5 transfers. You can see here that the results are all fairly similar. So in fact, it's not significant. It's 0.07. So both the AI systems, the doctors have always got the head around whether you should be doing cleavage or day 5 transfers. 35-year-old planning frozen transfers should have luteal sulfate. What I find, so in this case, 9, 10, 10, 9, once again, both the doctors and the AI models are actually fairly accurate in what they're saying. A 30-year-old woman, should I consider egg freezing? 9, 10, 9, 8. So also they all gave similar sort of answers. 30-year-old having fresh transfers, should I keep taking my support? 7.5, 8.5, 6.5, 3.5. Once again, I think that when the question involves taking pharmaceutical and taking medication, the AI systems seem to be a little bit more vulnerable, especially Gemini. But there's also more variability in how the referees assessed the two doctors' replies. Male patient having with spermatomegaly, should I take antioxidants? 9, 7, 7, 7. And even though it's significantly different, the answers are kind of much. Everyone assesses all the answers fairly similarly. Another ovarian reserve, should I take DHEA? 9, 7, 3, 5. And I think this is one other case where I suspect that the replies for the AI respondents will probably be simple because it's something to do with taking medication. I suspect AI really doesn't want to say very much, and the replies from the doctors are more nuanced. Should I have scratching? I find this one rather interesting. One doctor his reply was scored well by everyone, but Dr. B and the two AA ones they didn't actually like the reply. Basically, I suspect they said, don't do it. 35-year-olds and been diagnosed with endometriosis, 9, 9, 8, 7. So once again, in that clinical setting, the AI programs gave replies that were fairly consistent with the doctors. 30 years old and was diagnosed with infertility, should have IVF or ICSI, 4777. So in this case, Dr. A gave a reply that the referees just didn't like. And basically they were saying that you should just have IVF. 25-year-old with PCO and something about ovulation treatment. Should I take metformin? 8872. So once again, take medication. I think these AI systems are very conservative in what they say, basically very little. And lastly, should I measure my progesterone in the day of transfer? 7472. So in this case, it looks fair to me like ChatGTP and the two doctors are pretty close. The Gemini model is really quite poor in a lot of them. So this is what the doctors found. This study found that fertility specialists provide more reliable replies to patient questions than the AI models. Although AI tools have demonstrated considerable potential in diagnostic and interpretation of complex data across various medical fields, the number and quality of studies evaluating the performance in real-world clinic settings remain limited. So the author's thoughts. The internet remains a primary source of infertility-related information for most individuals undergoing fertility treatment. The anonymity and accessibility of digital platforms, particularly generative language models such as ChatGTP and Gemini, may further encourage patients to seek guidance from these technologies. However, the findings of the current set of questions suggests that for evidence-based decision-making in complex clinical contexts, the replies generated by experienced fertility specialists remain superior to those produced by leading AI models. But that was questions that were being judged by other medical fertility specialists. So a couple of reasons for poor AI performance, which in respect wasn't that before. ChatGTP was pretty good. Several factors may account for these findings. First, the data set used to train AI models are not publicly disclosed and may include outdated, low quality or non-peer reviewed information. That's fair enough. Second, AI-generated context is susceptible to hallucinations where the model produces text that appears coherent and plausible, but is factually incorrect or clinically misleading, sometimes with fabricated citations for non-existent articles. Wow, that's a worry. That is a worry. Third, AI models lack real-time access to updated clinical guidelines or recent literature. Since their training data reflect a fixed point in time, they may not incorporate the most current recommendations or evolving standard of care. And since I know nothing about ChatGTP, I don't know how often that's being updated, but I would assume there would be multiple versions of that. Fourth, these models lack clinical reasoning or contextual understanding. So the author's conclusion, in summary, fertility specialists outperform two leading AI models in providing accurate and reliable responses to complex clinical questions. While generative AI holds promise as a supportive tool in reproductive medicine, it currently lacks the nuanced evidence-based reasoning required for personalised patient counselling. Ongoing research is essential to refine AI's capability. However, at present, these tools should be viewed as complementary to rather than a substitute for expert clinical judgment. So my thoughts, finally we get to the end, my thoughts. I thought this was a good paper, simple to the point, and I quite enjoyed it. It showed that for any question, artificial intelligence models can provide an answer. These are not necessarily wrong, it's just that they could be better. It seemed that specific pharmaceutical-based questions are often poorly handled by AI models. At best, the better replies that are judged by medical experts were given by medical experts. And I think there might be something in that. In reality, though, despite what is available online, a doctor's advice is the only advice that is important. You cannot sue the internet for non-medical advice. Clinics need to be in control of the information provided to all their clients in a general way, since all clinics may operate in different ways. So each clinic will have their own way of doing it, and the clinic needs to be in control of the information that reflects what they're doing and not succumb to a generic form from AI models. But even within a clinic, individual doctors will vary in what they recommend. Some will do AI, artificial management, FET cycles, some will do natural cycles, some will do IVF, some will do ICSI. And so you're going to get a variety of answers depending on which doctor you see. But clinics should be aware of what artificial intelligence models do say and be prepared to support or counter their comments. And quite frankly, I thought the QA format was a good way to move forward on this. And I thought, just before I finish up, I might just go back to ChatGTP and put in the same question and see whether they give the same reply. And guess what? They didn't. So I chose the one which I've just done some recent videos on. 30-year-old single woman, should I consider egg freezing? And here's what it replied. I can share general educational information to help you think this through. For personal medical decisions, it's always best to talk to a qualified healthcare professional. What egg freezing is. Egg freezing, oocyte cryopreservation, is a medical process whereby eggs are collected, frozen, and stored for possible future pregnancy. It's mainly used to preserve fertility since egg quality and quantity naturally decline with age. And then it goes on to say why someone around 30 might consider it. From a biological standpoint, the early 30s are often considered a favourite time to freeze eggs because eggs are typically higher quality than later in life. Fewer eggs may be needed to achieve a future pregnancy. Success rates are generally better than freezing at old ages. People often consider egg freezing if they're not ready to have children yet, but may want the option later. They're single or don't have a partner. They may want more reproductive flexibility or peace of mind. There's concern about future fertility, family history, da. Important limitations to know. Egg freezing is not a guarantee of future pregnancy. It can be expensive, procedure, medication, storage, later IVF costs. It involves medical treatment, hormone injections, etc. And some people, and I think this is the really important one, I would like ChatGTP to have highlighted this or put a weighting on each thing. And I think this is important. 90% of people never use their freezing eggs. So I think ChatGTP should get a big tick for that. Questions often reflect on how important is having a biological child to me? How do I feel about cost and medical processes? Would egg freezing reduce anxiety or add stress? What are my realistic timelines for family planning? The only thing it didn't really do is say, if you don't use the eggs, you may have some decisions about what to do with them, freezing or donation, etc. And I think if ChatGPT had included that, I would have been seriously impressed with their reply. Okay, enough. The bottom line is egg freezing is optional, not necessary, and it's very personal. For some, it offers reassurance and flexibility. For others, it doesn't feel worth the cost or effort. There's no single right choice. If and when appropriate, a reproductive endocrinologist or ONG can explain success rates, risks, and whatever makes sense medically for an individual situation. And I don't think I could have done better than ChatGTP. And what I find interesting is that their reply is different to what the authors did when they submitted the question to ChatGTP. So one can only assume that from the time they started this project to now, ChatGTP has improved. And one can only anticipate. And I think that from this point of view, if you are as a clinic and are thinking of providing information about ChatGTP, you need to recognize it will always be being updated. And if you're using ChatGTP to generate generic information sheets, it will become out of date very quickly. Okay, so there were some differences between what was reported in the paper and what was just replied to my inquiry. Maybe with AI models, they will only get better as it learns from the questions it is asked. It seems to me, as a starting point, before one visits the clinic, its information is pretty good. Clinicians need to be aware of this information before they undertake their consultation. Maybe one question could be, have you asked ChatGTP? And were there any other questions? Could almost be like that. Okay, I'd like to finish now. So my name's James Stanger. I'm an embryologist. I'm got 50 years experience. I'm not a medical person. And this information is not medical advice, but it may help you in knowing what questions to ask about your treatment with your doctor and maybe to help in understanding you receive. If you like what I'm doing, press subscribe or add a comment. Go to my fund page if you want to give me some money to support what I'm doing, which I always need. And I'm slowly working on my Patreon CBD program. Leave a comment and tick like. Just one last plug, I run an EQA program online at fertility.com in EQA and training program in andrology and embryology. And there's lots of information you can see there. So I'd just like to finish. Thank you if you've persevered this long. I know IVF is a personal journey that involves the action of many techniques, concepts, and staff. It helps to understand all aspects of that journey. And if this information, I hope this information has been of value to you. If you like the information provided, please tell other clients about this service and please subscribe. And that, my friend, as they say, is your lot for the week. I'll do another video in the next couple of days. Thank you and goodbye.